The diagnosis of cystic fibrosis is made according to the following criteria: typical clinical presentation of respiratory infections, malabsorption of fat, a sibling with cystic fibrosis, postnatal screening together with an abnormal sweat test, pathological nasal potential difference, and/or the presence of 2 mutations that are known to be causing cystic fibrosis. In most cases, sodium concentration in the skin sweat sample is low. Chloride concentration can be easily measured, and in cystic fibrosis it is high, above 60 milliequivalents per liter. The test is performed by attaching a watch-shaped coil to the forearm and triggering a mild electrical current, which is not felt by the patient, to cause sweat formation. The collected sweat is measured for chloride concentration. Chloride level above 60 milliequivalents per liter is typical in cystic fibrosis patients. As the patient grows older, the sweat chloride levels are higher, and therefore in newborns, if the level is above 30, a repeat test should be performed. Infants 6 months and older should do a repeat test if the level is above 30, according to the new guidelines. A more complex test is the nasal potential difference test, which measures the electrical voltage drop between a small thin electrode which is placed on the nasal epithelium between the interstitial measurement, which is in the subcutaneous tissue on the forearm. The normal result is an electric voltage up to minus 20 to 30 millivolts. A milleride reduces this, and there is more negative potential when the chloride-free solution is run through the nose, which stimulates CFTR protein activity. In CF patients, however, the basal potential difference is much more negative. The response to a milleride is increased, and there is no response to running through the chloride-free or isobutanol solution. The test can be performed at any age. Some patients do not present with typical symptoms of classic cystic fibrosis. We now know there is a spectrum of how cystic fibrosis expresses itself, depending on the level of function of the CFTR protein. Carriers who have by definition 50% function will not show any symptoms, but as the protein activity decreases, disease symptoms manifest themselves with pancreatic function retained right to the end. Only when there is a sharp decline in over 90% of CFTR activity does pancreatic insufficiency appear. Patients with atypical cystic fibrosis will present with chronic or recurrent sinusitis, bacterial infections of the respiratory tract, and azoospermia, in males of course, resulting in the absence or blockage of the vas deferens. Some patients may present with acute or recurrent pancreatitis. Their sweat tests may be normal, may be borderline, or may be elevated. Clinical parameters in classical cystic fibrosis are diagnosis at an earlier age, pancreatic exocrine insufficiency, poor nutritional status, early pulmonary involvement usually, and usually elevated sweat tests. Atypical cystic fibrosis, as opposed to classical cystic fibrosis, the characteristics are diagnosis at a later age, pancreatic exocrine sufficiency, good nutritional status, and survival is much better. This is difficult to diagnose, and the sweat tests may be helpful or not. Some of the common presentations in atypical cystic fibrosis. Diagnosis of atypical cystic fibrosis is difficult because there is no one standard clinical picture or phenotype. Sweat tests may often be normal or borderline and cannot be used to make a diagnosis. Nasal potential difference are only performed in a few centers, in Israel only in Hadassah, and this is a national referral center. The patient's mutations may be rare or may not be tested in the standard panels. There are nearly 2,000 mutations known. Diagnosis is performed by performing the nasal potential difference test or the presence of 2 mutations, normally done by gene sequencing.